Welcome, everyone. I'm delighted to be here. My name is Alan Ho. I'm a professor of surgery at Cedars-Sinai Medical Center and a head and neck surgeon. I am also the co-director of the thyroid cancer program here at Cedars-Sinai. We're very excited to be presenting to you a conversation on active surveillance for early stage papillary thyroid carcinoma. And I'm very lucky to be joined by my illustrious colleague, Wendy Sacks. Wendy, would you introduce yourself, please?
Well, hi everyone. Hi, Alan. My name is Wendy Sacks. I'm an endocrinologist at Cedars-Sinai Medical Center and an associate professor of medicine at Cedars, as well as the other co-director of our thyroid cancer program.
It's a very interesting time to be managing thyroid cancer. There are many established principles, some evolving principles, and emerging ones as well. Would you mind giving me a brief overview of papillary thyroid carcinoma in terms of its incidence and how we're increasingly looking at it differently compared to the years earlier?
Yes, well, as you said, thyroid cancer is very prevalent in the population, and papillary thyroid cancer is the most common type of thyroid cancer, with an estimated almost 45,000 cases just in 2021. It is actually the most common cancer among adolescents and young adults, and the seventh most common among women overall. In general, papillary thyroid cancer, which is considered a well-differentiated thyroid cancer and comprises approximately 80% of all thyroid cancers, has excellent prognosis. And in general, localized differentiated thyroid cancer, especially papillary, has a very favorable prognosis with a near 100% 5-year survival.
Many people sometimes wonder if this is a product of overdiagnosis, and some people wonder if there's a true increase in diagnosis. Can you comment a little bit more about what these concepts mean for papillary thyroid carcinoma?
As you mentioned, there did seem to be an increase in the incidence of thyroid cancer. Worldwide, the incidence tripled from the 1970s through the early 2000s. There are studies that showed an increase in expected over observed thyroid cancers, and this seemed to be due to increase in screening and detection of small thyroid cancers. In about 2014 through present, it seems to have subsided in the sense that the incidence have leveled off.
What do you make of this leveling off of incidence?
Several things have been implemented to reduce the overall incidence of detection of thyroid cancer. One is that the American Thyroid Association endorsed not biopsying nodules that are less than 1 centimeter in size, even with suspicious ultrasound features. Another is that the American Thyroid Association endorsed active surveillance of small thyroid cancers, so 10 millimeters or less, or for those patients who had a high morbidity from surgery, or those who would not do well with having had a thyroidectomy. The United States Preventative Service Task Force guidelines to primary care doctors: you don't need to screen for thyroid cancer. So there have been all of these things that have implemented to reduce the actual diagnosis of thyroid cancer.
One thing that really gave me pause was not only all of the guidelines and task force recommendations you suggested, but just cadaver studies, which have really shown that a high percentage of patients who die of other reasons, such as heart attack, stroke, diabetes, if you dissect out their thyroid finely enough, you'll find an incidence of small thyroid cancers that is quite remarkable. In that sense, many people are living with this disease and dying with this disease, but dying of something else without even being detected. So it has really given us as surgeons this pause in regards to what we should be doing. And I think that has brought us to what we are discussing today, which is that not only are patients eligible for surgical approaches, but also this concept of active surveillance. Wendy, would you give us some of the reasons that active surveillance exists and why it may be useful for early thyroid cancer patients?
Well, that lends well, Alan, into the group from Japan who started an active surveillance program back in the early 1990s, where they detected through screening a very high incidence, particularly in young women who were screened at the time of mammogram with a thyroid ultrasound, where they detected many small thyroid nodules. And because of the higher number of thyroid nodules detected, thyroid cancer was detected by biopsy. The group offered active surveillance, and over time, they were able to follow approximately 1,000 to 1,500 cases of 10 millimeter or smaller thyroid cancers. And what they found was that there was very slow growth, if any, growth. And by growth, they determined a 3 millimeter or more increase in size of the tumor, or if there was a novel or new lymph node metastasis. They published every 5 to 10 years their results, showing that there were very low rates of actual growth of these small tumors and very low rates of new lymph node metastasis, from 3% lymph node metastasis and up to 10% of increase in size of 3 millimeters or more. Some patients opted for surgery down the road due to anxiety, typically. They showed that for the patients who either opted for surgery later or required surgery later due to progression, these patients did not have an adverse outcome or an increased risk for recurrence despite their delayed surgery.
That's very important to note. It more or less speaks to the idea that if you have delayed surgery or what they might call rescue surgery for growth or anxiety or progression, you do just as well as compared to patients who had surgery right away up front without any active surveillance. And I think that just speaks to the concept that the window of safety, the window for cure, is fairly wide open. And just because it has progressed, say 3 millimeters as you've described, it's not so much a major setback, and in fact, progression may be expected. That's what rescue surgery is for. These patients do fine either way. This therefore really creates a nice option for patients who don't immediately want an operation. As we know, surgery itself is not necessarily morbidity free, although it generally is a safe operation. It can be done as outpatient. Patients are back to work within a week or two with minimal pain. There are a small risk of complications that we can't really ignore. They include things such as vocal cord paralysis, hypoparathyroidism, and then finally, the idea that you're actually sacrificing a perfectly functional organ that's producing thyroid hormone. We really can't forget that fact. The thyroid cancer is really not affecting the organ itself. And so something like active surveillance may be very useful. Can you tell us a little bit more about how active surveillance works?
At our center, we have a protocol where we monitor nodules up to 2 centimeters. The majority of studies so far, however, have looked at and monitored in an active surveillance protocol up to 1.5 centimeters. Our protocol does include some larger tumors. I find the most challenging part of active surveillance is selection. Who are the patients that we really can be comfortable with advising to that active surveillance would be okay for them? This doesn't always depend on size. Even an 8 millimeter nodule in a posterior location in the lobe approaching the recurrent laryngeal nerve may not be a good patient to advise for active surveillance compared to a 1.5 centimeter nodule in the middle of the lobe that doesn't show any extension to the capsule of the thyroid or posterior location.
That's very interesting. So you're saying that size is actually a crude estimate or measurement of whether a person is eligible for active surveillance. If it's a small cancer very close to a critical structure, you're more likely to recommend surgery. And in contrast, if it's a larger cancer, in this case up to 2 centimeters in our center, that is well away from anything dangerous, you're more likely to say, no problem, let's watch it and observe it carefully. Is that what you're trying to say?
Yeah, that's exactly right. Another difficulty in the decision making for active surveillance is assessment of lymph nodes. Um, the ultrasound is extremely helpful, but not always adequate because the thyroid gland is still in place and we can't, adequately assess for lymph node involvement behind the thyroid. As we discussed, women have a higher incidence of thyroid cancer. They also have a higher incidence of Hashimoto's thyroiditis. And with Hashimoto's comes lymph nodes in the neck. And sometimes those lymph nodes can be difficult to differentiate from metastatic lymph nodes. So while a patient might have a small tumor, a small thyroid cancer, and they also have Hashimoto's, if there are parathyroidal lymph nodes, it may be difficult to assess for metastasis.
The perfect segue to another comment I wanted to make. In order to successfully achieve a good practice in active surveillance, one needs a good team, right? So someone who is focused on doing thyroid ultrasounds is much better equipped to recognize lymph nodes that others may miss, or recognize lymph nodes that are more cancerous versus a Hashimoto's type lymph node that you're describing. I think another part of the rubric is having a very open-minded team. If you have a progressive, open-minded team and willing to learn from each other, as I've learned from you, along with an excellent supportive base, a referral pattern, as well as radiology expertise, whether it's from the physicians or from radiology itself, then I think you could really set the stage for an active program that can thrive with surveillance as just another approach in order to treat this more indolent cancer.
Exactly. I think as I do this more often now, it becomes even more clear to me that you have to have a multidisciplinary team with a surgeon, endocrinologist, as well as the radiologist, who all agree that a particular patient is an appropriate candidate for active surveillance.
I would love to jump off of that comment and
Okay.
highlight the idea that you have a team that is multidisciplinary and progressive in nature has led to perhaps the trial that we have recently published, which has expanded the parameters for what is appropriate for active surveillance by building off of the pioneering studies in Japan and our other colleagues in the United States and elsewhere. And by establishing trust in the practice, we've expanded our eligibility for patients to not just, again, as you say, 1.5 centimeter cancers, but 2 centimeter cancers, but also allowing it more room to grow. So instead of a 3 millimeter cutoff, we're using a 5 millimeter cutoff. This expands the eligibility for active surveillance to actually about 75 to 80% of thyroid cancers, since the majority of thyroid cancers in the United States, at least, are 2 centimeters or less. So I think in that sense, it's very exciting to be able to prove feasibility for active surveillance for a large number of thyroid cancer patients, whereas before I believe that other physicians might have been more reluctant.
We're at a tertiary care center and we have access to excellent radiology, surgical assessment, and endocrine assessment. We can allow for these expanded parameters of active surveillance, and especially as part of a clinical trial, and we've shown that expanding these parameters is okay so far. But it does bring into question whether this can be brought into the community. And I think we don't yet have the answer for that. I think that as you approach 2 centimeters, the assessment for capsular invasion or extrathyroidal extension, as well as lymph node involvement, does need to be very carefully assessed. you and I have seen patients who have smaller tumors where they, let's say, end up going for surgery rather than opting for active surveillance, and we see pathologically they have a more aggressive variant of thyroid cancer or lymph node involvement, micrometastasis that we couldn't detect on ultrasound.
As
So
a
we
follow-up to that point, I think that brings us to the larger question of the limitations of active surveillance. I think what you're speaking to is one of our findings in that patients who are eligible for active surveillance um, and met our criteria to be observed underwent surgery anyway, and about 18% of those patients on final pathology were identified to have aggressive or intermediate risk features that would have disqualified them from active surveillance if we had known upfront. This speaks to the limitations of ultrasounds that you're describing, and that we really don't have a very fine-toothed instrument to determine who is eligible and who isn't. Now, the fact that they have those intermediate risk features doesn't mean that they would have necessarily progressed or had a lethal outcome. But it does tell us that we have to be a little more careful of who we select.
on the physician's side, making sure that physicians know how to properly assess a patient who is appropriate for active surveillance. And then on the patient end, the physician has a duty to discuss all the options for care, which includes surgery, active surveillance, and the extent of surgery. But it really does take a lot of time, actually, for the physician to discuss this with a patient.
I think these patients have to be prepared to be compliant. It'll take years to decades of ultrasounds on a 6-month or 12-month annual basis to determine if they will continue to qualify. So if a patient's not compliant, if they come from far away, if we feel that they may not be someone who will listen to our instructions over time, then perhaps surgery might be what we might describe as a cleaner, more definitive approach. The other thing that I wanted to echo that might be a detriment to active surveillance is that of patient preference. Patients who are anxious and may perhaps losing sleep, being very worried and constantly calling about their ultrasound and their diagnosis, they perhaps may not be a good fit for surveillance. They may be a better fit for an operation where it perhaps may give them some peace of mind. But that's the case-by-case basis, would you say?
Absolutely. I think that oftentimes it's the patient's family who really decides for the patient that they should move towards surgery as initial therapy, even though the patient is less anxious. I think your comment about continued surveillance is a very important one. We have found that having someone like a research coordinator to help us keep track of follow-up of our active surveillance patients has really been crucial. It's very difficult for physicians in practice to have the resources to keep up with all of these active surveillance patients. So hopefully in the future there will be very clear guidelines for those patients who we can do active surveillance on, risk stratify those patients, and perhaps over time there will be even less monitoring so that patients don't fall into a poor outcome because of lack of follow-up.
So I'm very curious about what you might think about the future prospects of active surveillance.
I do think that there are very clear patients who benefit from active surveillance, and that this will continue to be identified over time. And I think that molecular testing can be a future modality for helping us determine who are best candidates for active surveillance versus immediate surgery.
I also would add that in the treatment rubric, as we think about not only molecular but also patient, there are many interesting research opportunities down the pike in regards to decision aids, conversation aids, in order to elicit patient preferences that will perhaps help us as clinicians better determine whether a patient's a good fit. Well, any last comments before we wrap up this interesting conversation?
absolutely agree with you regarding decision aids, and I want to thank you for moderating our session.
Well, great. Thank you, Wendy, for joining me.